our special webinar about ambulatory EEG service, sponsored by Neurovation and organized by WWA event. It's my pleasure and honor to welcome our guest speaker, who is very well known in the field of epilepsy and EEG, Professor Roger Oglakian. Professor Oglakian is a neurologist, epileptologist, and EEGer, board certified. He's the founder and the president of Expert EEG Interpretation Company and Tele-EEG Monitoring and Epilepsy Consultancy. He was the director of Epilepsy Services and EMU at Mercy Health System in Springfield, Missouri from July 2011 until December 2020. Currently, he's the medical director of Innovative Diagnostics. He has many publications in the field of neurology, epilepsy, and EEG. Professor Oglakian today will present to us a talk about ambulatory EEG service as a new standard in post-COVID era. Professor Oglakian, please, mic is yours.
Thank you very much, Dr. Al-Jafari. Thank you everyone for joining us this afternoon. I'm glad I understand we have probably close to 2,500 people registered and joining us tonight. And I'm glad we're not sitting all in one conference room with masks on. I'm sure everybody's more comfortable at home this way. Thank you for the introduction. Before I start, I'm gonna give you some disclosures. Like Dr. Al-Jafari mentioned, I am currently a medical director and an EEG interpreter for Neurovation Diagnostics. I also interpret EEGs for another large EEG company in the United States called Cordially for both inpatient and outpatient ambulatory EEGs. And I also interpret EEGs for both EMU and ICU patients in several United States hospitals. My background, like Dr. Al-Jafari said, is in epilepsy. I ran an epilepsy service at Mercy Hospital for about 10 years. We had a 4-bed EMU, and I ran a full-time epilepsy clinic. And in addition to the 4 EMU beds, we had a service of about 15 continuous EEG machines for monitoring of patients on the wards, on the floors, on the medical floors, neurology floors, and obviously in the ICU. Currently, my focus is EEG and epilepsy consultancy in the field of telemedicine, especially with COVID and telemedicine becoming almost close to a standard these days for a lot of healthcare systems. So let's start a little bit with some general background, which you probably get with almost every epilepsy presentation. Therefore, I don't want to spend too much time on it, but just a quick reminder. Epilepsy is a disorder, obviously, of the brain that causes a predisposition for seizures. It is one of the most common neurological conditions worldwide. Close to third or second most common presentation to hospitals, emergency rooms. It is extremely common and at times, unfortunately, underdiagnosed. There's an estimated 50 million people worldwide with epilepsy. And a lot of them, 3/4 of them, live, unfortunately, in resource-poor countries with little or no access to medical services or treatment. But that does not mean that in richer countries that all resources are available or at least used appropriately. There are countries, including the US, where we do not use all the resources, unfortunately, that we have. They are there. One of the big ones is EEG, and another one is the access to epilepsy surgery, which again is very underutilized in the United States and in the world. In the US, there is an estimated 3.4 million people with epilepsy. As we know, usually the general rule is that approximately 30 to 35% of patients with epilepsy have what we call medically intractable epilepsy. They have tried 2 or more appropriately used medications for an appropriate amount of time, yet their seizures have not been under control. My understanding, in Saudi Arabia, the prevalence of epilepsy is approximately 6.5 per 1,000 people, which puts approximate total number of 222,000 people with epilepsy. As we know, electroencephalography is the gold standard for diagnosing epilepsy and seizures, and also, by extension, for ruling out epilepsy and seizures. We go back almost 100 years since the first EEG recording was done. Interestingly, it was done intraoperatively during a neurosurgical procedure on a human patient. So first one was 1924. The first spikes or abnormal, epileptiform discharges were determined around 1934, 1935. The first laboratories for EEG testing were established in the United States in the 1930s and 1940s. This obviously has gone a haul over the years from going from papers and stacks of tracing on paper to digital EEG. And we probably all now don't even remember how EEG used to look like as early as the 1980s and 1990s. The first digital EEG that was miniaturized in a way where it became portable was done in the early 2000s, and it was actually invented, if you want, by Lifelines, which is a company currently very active in the development and improvement of ambulatory video EEG systems, and also is partnering with Neurovation Solutions to provide that kind of service in the Arab countries, specifically in Saudi Arabia. The video edition, which was one of the biggest limitations prior to that, was done in 2007, so mid 2000s, but first used in 2007, where there was concomitant video recording along with the EEG recording synchronously, as to not only look at brainwaves, but also look at behavior and be able to capture seizures or seizure-like events. So going over the different types of EEG recordings, just so we have an idea of where we are today and where we were several years ago when those other types were not necessarily available. Obviously, the most common and probably the most used EEG or ordered EEG is what we call a routine or a standard EEG. The recording clearly is a short recording. It lasts about 20 to 40 minutes, depending on the age of the patient, whether they're pediatric population or an adult patient, etc. And it is performed in a lab, usually, not to say that it cannot be done in a patient's own home, but the usual test is performed either in clinics. A lot of clinics have EEG machines that can perform routine or standard EEGs, or they're done in specialized laboratories, neurophysiology laboratories or EEG laboratories inside hospital settings. And they do include activation procedures that include hyperventilation, where the patient is asked to hyperventilate for a short period of time, to look for any abnormalities, and also includes photic stimulation. Some of those activation procedures do at times in certain epilepsies bring on abnormalities that we otherwise do not see, such as 3 Hz spike and slow waves in absence type of epilepsies in children. The second type is another type of routine or standard EEG where the patient is asked to refrain from sleeping the night before the test. So the technologist or the test can capture sleep during those 20 to 40 minutes. Sleep is at times another quote unquote activation procedure where certain abnormalities tend to appear more during sleep. And obviously during sleep, we do most of the time get rid of the most of the myogenic or EMG artifact, thus clearing the field to find any subtle abnormalities such as asymmetries between the hemispheres and obviously epileptiform discharges that may not appear during awake state or may be masked by myogenic or EMG artifact. So very similar, but we ask the patient to be sleep deprived. At times, patients cannot tolerate staying awake all night. So we do tell them to stay awake as long as possible. And then if they need to sleep, to actually put an alarm early in the morning so they don't get to sleep more than 3 or 4 hours. And that way we increase our chances of catching some sleep stages during the EEG. The next step in usually evaluating patients who are presenting to us for seizures or seizure-like episodes or for other diagnostic things such as evaluation for surgery, pre-surgical evaluation, quantification of seizures, finding where the seizures are coming from, so the epileptogenic focus, and also intervening when necessary with changes in treatment and medication. For those, the next step would be long-term video EEG monitoring. And those are divided into 2 major categories at the present time. The most common, or at least the previous most common testing that was done as a next step to routine EEG is the inpatient video EEG monitoring in specialized centers that provide what we call the epilepsy monitoring units. These are specialized units hardwired with computers and video cameras where long-term monitoring is performed. It is obviously performed over a period of several days, and it is dedicated to the epilepsy monitoring units, as we said, and they have synchronous or concomitant video recording. Now, the ambulatory EEG is what we started doing, like we said, in the 21st century, in the early 2000s, and then added video in 2007 at Lifelines, and is currently being used very, very, very commonly. And it is exactly the same as far as the testing goes as the inpatient video EEG monitoring. It is recorded over several periods of time, over several days. However, it is performed in the patient's home. And we'll talk more about that as we go along in the presentation. Let's look a little bit at the yields of the different types of EEGs. As we probably all know, routine EEGs usually have very low sensitivity. They have good specificity, but they don't have very good sensitivity. Some studies, the range is pretty wide, but at best, even in the best case scenarios, the sensitivity of an EEG to detect epileptic discharges or be able to confirm or diagnose a patient with epilepsy or an epileptogenic focus at best is at 55%. And the range is anywhere between 20 to 55%, depending on the type of epilepsy, on the severity of the epilepsy, and several other factors. But again, the range is 20 to 55%. So at best, we're missing almost at least half of the patients by just doing a routine EEG. Now, if we do repeat those EEGs several times, the same routine EEG done multiple times, we do tend to increase the yield or the sensitivity up to 80 to 90%, but that requires up to 4 repeat routine EEGs. That's usually not an easy task to perform. It's not easy to ask a patient every month to come in and spend an hour and a half in an EEG lab to get a number of repetitive EEGs. And we also are wasting quite a bit of time. So, you're wasting time to be able to intervene, treat, start medication, change medication, or even diagnose the patient with epilepsy. During that time, if a patient is presenting with a seizure-like episode, you're telling them not to drive. You're telling them to be careful when they're doing certain activities. So imagine having to extend that diagnostic period up to 3 or 4 months just to be able to repeat EEGs. And again, it's never going to be 100%. So the chances of finding inter-IED, stand for inter-epileptic discharges, is increased by repeating routine EEGs. Now, when we go to the epilepsy monitoring unit, to the inpatient video EEG monitoring, clearly some of the best yields is what we get in the EMU. It provides a definitive diagnosis in approximately 75% of admitted patients. So every 3 out of 4 patients who are admitted to the EMU leave the EMU with a definitive diagnosis. Not to say that diagnosis is epilepsy, but it is a diagnosis that we can tell the patient about with certainty. Now, if we look at the ambulatory video EEG, the ambulatory EEG provides a yield in approximately half of the patients that were previously non-diagnosed, had a non-diagnostic EMU admission. That's huge. That is a study that was done in 2009, and it showed that patients who had a negative or non-diagnostic EMU admission, and we ended up doing an ambulatory EEG after their EMU admission, half of those patients, we were able to find a positive diagnosis, or actually be able to give them a definitive diagnosis. That's actually very, very good. One study showed that 57% sensitivity in patient for doing with long-term EEGs of more than 48 hours had a positive EEG, long-term EEG, when they had a normal routine EEG. Some of them several normal routine EEG. So several normal routine EEGs, and then doing an ambulatory, we're up to 57% in terms of the yield. And very importantly, it had a negative predictive value of 91%. That is actually pretty big, because that tells us that we were able to rule out epilepsy in 91% of those patients. So not only we have a high chance of giving a definitive diagnosis, we had a chance of finding epilepsy in over half of the patients that had normal routine EEGs, but we had a huge chance of telling patients they did not have epilepsy by doing this long-term EEG. Obviously, let's look at the rationales for long-term monitoring. A lot of times in the community with family physicians or internists or family practitioners, and sometimes even neurologists with limited resources, patients end up getting one EEG and that's it. And then whether the patient is treated or untreated, medications are started or not, or whether there are changes to the treatment or the management, that's left to the discretion of the treating physician, but only based on one EEG, which, like we said, could be very well negative. So the rationale, as we discussed, one, overall low sensitivity of routine EEGs. So we're doing a test that's not giving us any answers. Two, we clearly, again, because of the low sensitivity, in other words, we're just saying that a normal routine EEG clearly does not rule out epilepsy. Three, some epileptic patients do not have interictal discharges despite repeated routine EEGs. So what that means is, remember, we said up to 4 EEGs and we might increase the yield to 80, 90%. However, there is a number of patients out there that have epilepsy, but they don't have indirect epileptiform discharges. Therefore, the only way to confirm their diagnosis of epilepsy is really to capture an episode, because we can repeat EEGs if they don't have interatrial discharges, and if we don't capture an an seizure during those 20 to 30 minutes recordings, then we will tell the patients we can't find their diagnosis, or you don't have epilepsy, which is obviously not the case. Again, in the same realm there, we're saying that with routine EEGs, we have a very low chance of capturing a typical event. That's why long-term EEGs with video have much higher chance of capturing those events. We talked about the hassle and cost of repeating EEGs and the time that we're wasting doing those EEGs until we make a decision whether to treat or not to treat, or whether to give a patient an actual definitive diagnosis. Another rationale for doing long-term EEG is, let's say we do routine EEG and we're not sure, and it's non-conclusive, it's not showing anything epileptic, but yet the story makes sense. But so we start the patient on medication because we think these are true epileptic seizures, and then we try one or two medications, yet they still continue to have seizures. At that point in time, we have to obtain a long-term video EEG to be able to be sure that we're treating the right condition, that we're not treating non-epileptic spells, and that if we capture it, we can confirm it and then characterize that epilepsy and may be able to change the management depending on the type of epilepsy that we find. Obviously, one of the big rationales behind doing long-term EEG is to evaluate patients for non-pharmacological or surgical options, which now are many. The oldest and probably one of the best outcomes are with resective surgery. Then laser ablation surgery is obviously being performed quite routinely here in the US. And some of the other non-resective interventions, such as vagus nerve stimulation, responsive neurostimulation, and deep brain stimulation, all currently approved for the treatment of resistant or medically intractable epilepsy. One of the biggest hurdles we have here is overtreatment or overdiagnosis or misdiagnosis of seizures. We have probably close to 20 to 30% of patients that we unfortunately diagnose with seizures based on history and based on initial routine EEGs, yet they turn out not to have epilepsy, and that their seizure-like events are non-epileptic. And there's a wide range of other differential diagnoses here, including the functional seizures or psychogenic non-epileptic seizures, previously called pseudo-seizures, and some other types of spells, including cardiogenic spells or syncope, etc. And your usual long-term video EEG monitoring ranges anywhere between 3 to 7 days. And that's based on some studies in the past, actually, a while ago, showing that, the first, for example, temporal interatrial discharge only appears after about 4.5 days of monitoring. And it is really targeted or individualized for every patient, depending on the type of seizures, type of events, the frequency of events, severity of events, whether they're on treatment or not. That all, plays a role and is a factor in determining the length. But the usual range, I would say the median or mean is about 5 days, but it can go anywhere between 3 to 7. So again, like we said, the number of days in the hospital or in the EMU or for long-term ambulatory video EEG depend on factors such as, are these epileptic or not, the type of epilepsy, whether we're doing a pre-surgical evaluation, and sometimes we have to keep patients longer if we haven't caught any events, and obviously the spells and their frequency, and that would determine the length of the study. Now let's go to a little bit of a comparison. We have the gold standard, which is the epilepsy monitoring unit, and now we have a new direction, a new potential standard, if not better, which I won't say it is better, but probably equal or close to equal in the right patients, obviously. Looking at those pictures and telephones that we used back in the day with the iPhones that we use now, clearly, if you ask me, I'd rather have the iPhone. And and not be tied to a phone that is corded and has 3 feet of cord plugged into the wall. Same with this. I mean, look at us today having a live online Zoom or whatever it is meeting with thousands of people versus back in the day when we were all crammed into a conference room taking notes instead of being in the comfort of our own home drinking our coffee. Here is the actual picture of how it looks like. You can be in the EMU. This lady is obviously not very happy. So you can be in the EMU tied into a bed. You can go to the bathroom. You can sit probably on the commode or a little chair or sofa next to the bed, but you're just sitting there for several days in the hospital, a lot of times by yourself, versus this other young lady sitting at home, taking notes and pretty much doing her normal daily activity. For kids, even more of a hurdle. I mean, it's harder to get epilepsy patients, pediatric epilepsy patients in their in the EMU than adults. You could see a child on the right-hand side playing at home, doing his normal activity versus a child that is tied in and we're trying to keep entertained for 3 to 5 to 7 days. Let's start with the epilepsy monitoring unit. Advantages, pretty clear to pretty much everybody. It's a controlled setting. We have cameras that are looking at the patients all the time. The patient is in a relatively small room. They can't go anywhere. And if they do go onto the sofa, the camera will rotate around and there's somebody that's doing that, looking at them at all times. And, you know, also if there are any technical issues, the technologists will run into the room and fix them almost immediately. Not to say, now again, we have to understand that usually level 4 epilepsy centers or epilepsy monitoring units are the ones that have 24/7 monitoring with technologists. However, some of the level 3 and below, it's not a requirement. I mean, by standards of our Medicare or Medicaid or, you know, payers, it's not a requirement to have a 24/7 monitoring, but in a level 4 it is for sure. A big advantage of the hospital stay in the epilepsy monitoring unit is the fact that medications can be reduced or can be tapered off or can be adjusted. So different goals there. If we're trying to capture seizures and doing some type of pre-surgical evaluation, we want to taper off medications if the patient is known not to have too many seizures on medication. That would allow us to do it in a safe environment, in a very closely monitored environment. In case certain rebound seizures occur, we will be right there to intervene, to inject benzodiazepine or restart medication, whatever needs to be done. So that's a big advantage. It is something that for pre-surgical evaluation stays gold standard. I mean, if we're really, really looking into an epileptogenic focus and exactly where, and we're kind of looking into a 2-stage monitoring with both scalp monitoring followed by an invasive monitoring potentially, obviously the EMU is the place to be at. Again, with level 4 centers, we're monitoring 24/7, continuous monitoring by EEG techs. Now let's look at some of the disadvantages. First one is clearly the long bill. And can be a hassle because although insurance companies will pay the bigger chunk of the tab, patients sometimes end up with quite a bit of a big chunk to pay out of their own pocket. And just to put it in perspective, in the last few years, I would say probably 3 to 4 years, a lot of the insurance companies have required an ambulatory video EEG to be done, and they would approve that before an admission to the EMU is scheduled. Meaning if I send a patient to the EMU, I've gotten calls from insurance companies saying, we cannot approve the EMU unless we do a long-term EEG first. And if that's non-diagnostic in certain cases, I mean, if I'm admitting for a pre-surgical evaluation, they're fine with it. But in certain cases, they will say, no, you got to do the long-term video EEG first before you go into before the patient can go to the EMU and be approved for the payments. it is a low stress environment. Now you would say that's a good thing. Well, not really, because a lot of patients have seizures that are triggered by stress. And stress can trigger both epileptic seizures and can trigger functional non-epileptic psychogenic seizures or pseudo-seizures. So people say, well, if I have true epilepsy, what does that stress matter? Well, it does. Stress does matter. So if you're on a very, very low stress environment, sitting in the hospital, being served food, lunch, breakfast, dinner, not running around the kids or the pets, then you may not have a seizure because of that low level of stress. Scheduling time is definitely longer than the routine and the ambulatory EEG. In my center, it was anywhere between 4 to 12 weeks. So it's sometimes a disadvantage because you want to find answers and patients want to find answers, or you want to intervene, or you want to change medications, yet you can't because you're waiting for that EMU admission. And that is because of the limitation of beds and the limitation of technologists. A lot of hospitals have the beds, don't have the technologists. And some hospitals don't have enough beds or have a high population, and that's why there's a long waiting time. In this era, there's been a lot of restrictions with COVID. I remember last year, we had to shut down the EMU for approximately 2 months because it was considered an elective procedure, and they didn't want to do any elective procedures in the hospital because of the risk of exposure from patients in the hospital or from to patients in the hospital. One of the advantages is a commitment to the long hospital stay. A lot of people don't like that. They don't like that. They don't like to be in the hospital. They just don't want to be in the hospital. They'd rather do things at home. There's a relatively low flexibility in usual cases because when you have an EMU with a limited number of beds, you're scheduling patients back to back to back to back. So if you schedule patients on average 5 days, you're scheduling a patient on Monday and then you're scheduling another patient on Saturday. That previous patient needs to leave on Friday because the next patient is coming to take that bed on Saturday, unless you just have to cancel that other patient. So a lot of times there's little flexibility there. Now, ambulatory EEGs, let's look at the advantages here. With ambulatory EEGs, obviously, one of the big things is much less costly, very cost efficient. On average, a hospital EMU bed is almost double the cost per night than the test itself. So if you pay $1,000 or the insurance company pays $1,000 for the night for an ambulatory 24-hour EEG or for an inpatient 24-hour EEG, it probably has to pay $2,000 extra for the hospital bed. So that's definitely a big one. Testing in the comfort of the patient's home. I mean, there's no explanation to do there because you're home, you're doing everything you want to do, pretty much, well, some restrictions, but definitely better than being in a hospital bed. It does provide the typical environment and level of stress. So if I'm stressed out and that is causing my seizures or seizure-like events, then it's going to happen at home. Then the duration might be shorter because once it happens, I can stop the monitoring. So definitely that's a helpful thing. There's a short waiting time. Most of the time, scheduling is done within 2 to 4 weeks, and if the insurance approval is there, scheduling is relatively easy and very straightforward and quick. There is a flexible study duration. Those machines are in the patient's home. If we do find out that the patient, we ordered a 3-day study and they didn't feel the thing, they didn't have an episode, in this era, we can extend that study. We can extend it longer or start with a long study. And if we have all the answers we need sooner, then we can actually cut it short. There is now the ability to monitor daily. So no longer really an advantage of the EMU. The only advantage of the EMU is you can immediately intervene through the text coming in and doing something. But at home, we now can monitor daily, either continuously, which is more common ones where, it's monitored every 1 to 2 hours or about 90 minutes, where a tech goes in and does a scan of the EEG. And if there is an intervention needed for technical issues, it can be done. It's not as fast as the EMU, but it can still be done. It might take a few hours or maybe a day to go in and fix it. But then the flexibility there for duration, where we can extend it if we lost some data for artifact. It is very convenient for patients requiring constant care at home, disabled patients who can not ambulate easily or cannot be brought to the hospital easily. There are a lot of people who have phobias of the hospital, a lot of people who have jobs, who have kids to take care of, pets to take care of. And in this era of COVID, a lot of people are working from home, online. And this is really very helpful because they don't have to take time off of work. They can still work. Their employer won't even know they're actually having a test because they're still working at home. Again, we talked about the restrictions and the risks here. So the disadvantages is the big one again here is to reduce AEDs safely. We can't do it most of the time, but again, not every patient that's going to have a long-term EEG needs to have a reduction or change in medication. There are those first-time seizures or new diagnosed epilepsy patients or patients with seizures whom we haven't started medication on. Or some people who actually we started medication on, they stopped it because they couldn't tolerate it, and now we want to find out if they're truly having epileptic seizures. So a lot of times it's okay not to be able to, or there are patients who are on medications who are still having some episodes. We can't figure out really how often, and we want to quantify them, and we want to make sure that they are epileptic seizures. There's potential delay in correcting technical issues like we discussed, and patients may not be on camera all the time. They are at home. The camera is just monitoring a certain angle, which on one hand is a benefit because we understand that a lot of people, they have their privacy. They want some privacy. They don't want to be on camera all day long, or their family members don't want to be on camera. You can be off camera. It's okay. You can be off camera. At times, it's not a big deal. I'm not going to stop a test because of the camera. So if you don't want to be on the camera at all times, you can move away from the camera. You can have your privacy anytime. It's like going to the bathroom in the epilepsy monitoring unit. And what I tell my patients when they're having their ambulatory video EEGs, hey, listen, if you're off camera, and if you feel like something is going to happen, like an aura, or you're having a spell that is a subjective spell, or a spell where you're not losing consciousness, make sure you just walk straight to where the camera, in front of the camera, and sit down in front of that couch or on that couch or in that bed where the camera is, or have a family member actually turn the camera around. So there are ways around that. People think that the video EEG is very artifactual, ambulatory video EEG. It's actually not. There is definitely some artifact, but it's not that bad at all. In a lot of cases, I feel like they're even less artifactual than the hospital stay. And the studies show that, 3 different studies with less than 1% in one study, about 2.5% in another study, and 0.3% in the third study, where the interpreters found that the EEG was uninterpretable because of the artifact. So again, very, very low numbers. Let's go over some studies here that do some comparisons, some of the biggest ones here that compared ambulatory and video EEGs. One in 2017, it was a prospective study. It compared the results obtained from video ambulatory EEG with the conventional inpatient video telemetry or video EEG monitoring. They looked at the diagnostic efficiency, which mostly is what we care about. The quality of the video, also really important, and the acceptability to patients. Did the patients like the inpatient better, or did they like the outpatient better? So really nice primary outcomes and secondary outcomes here to look at and comparing. The amount of extra technologist time required for home studies over conventional inpatient video telemetry was another secondary endpoint they looked at. So they included about 41 patients for ambulatory video EEG, and then 64 patients for inpatient video telemetry. All patients were monitored for 48 hours. So in the results, they saw that 74% of patients monitored with ambulatory EEG actually had typical attacks. So three quarters of them, really good number. That in the inpatient setting, there was 62% of the patients had atypical attacks. Again, going back to that, low stress environment, probably not enough triggers out there in the epilepsy monitoring unit. So definitely less attacks seen in the EMU than in the, at least in this study. In terms of final diagnoses, they were able to diagnose epilepsy in 12% of the ambulatory EEG patients compared to 16%. By the way, I'll go through all the results, but none of it was actually statistically significant. So pretty much comparable. Non-epileptic attacks, 24% capture in video ambulatory EEG, 61% in inpatient. In terms of some parasomnias, a lot of parasomnias diagnosed with the video ambulatory EEG versus about 10% in the inpatient population. As far as non-epileptic events, there was 8 of them, including cardiac, daydreaming, etc., staring spells, behavioral spells, 8% in the video ambulatory EEG population versus 13 in the inpatient video telemetry. Patient referred for differentiation of epilepsy versus non-epileptic attacks. The diagnostic questions, that's the big one. This is really a big one. We get that a lot. You know, seizures is a term that is used very commonly for everything that shakes, whether it's patients, sometimes even family practitioners. They say seizures or seizure-like events. Anything that shook is a seizure, or anything that stirred was a seizure. So actually answering that question was very comparable, even a little better, not statistically significant, but 67% in patients with the ambulatory study and 63% with the patient on the inpatient side. To diagnose parasomnias, the question was answered 72% of the time with the ambulatory study and 86% with the inpatient study. So attacks were clearly visualized in 76% of video EEG studies or ambulatory EEG studies. So that's really actually was even better than the inpatient for some reason. So they were able to see what was going on during an attack. Nighttime video was good quality in 85% of the study, a little better in the inpatient side, on the inpatient side. As far as satisfactory for interpretation, as you can see, for the doctors that actually were reading those, it was more satisfactory to read an ambulatory. So the study was better in terms of interpretation in 97% of the time. 15% of video EEG and 20% of inpatient study expressed no preference whether they would have done it in the hospital or at home. 80% of the patients that did it at home were very happy that they did it at home. And 5% preferred to be admitted instead of having done it at home. And out of the admitted patients, 45% said they would have rather been at home, and 35% said they actually didn't mind being in the hospital. So people who liked it at home is, again, the things that we actually discussed: increased comfort, dislike of a hospital, more peace at night, increased likelihood of having seizures, and easier to manage childcare arrangements. Inpatient preferences was the perception of more secure, or of insecurity at home and being kind of more secure in the hospital setting, and because you know you have the supervision of the staff at all times and nursing. So the conclusion that both studies provided similar quality and similar diagnostic efficacy. Patient overall preferred the in-home studies, and one parameter they looked at is that there was no extra technology time needed or required for the ambulatory study compared to the inpatient study. Big thing, it was a reduction in cost, clearly. The second study in 2012 was also a prospective study. The purpose was to differentiate epileptic versus non-epileptic. Again, a big question that we have all the time. The frequency also, and also looking at the frequency of seizures and epileptiform discharges, the characterization of seizures and localization, the potential diagnosis of epilepsy, and basically all the questions we always ask and we refer patients to the long-term EEG for. 101 patients were included in the study. Recording time ranged from 24 to 72 hours. There was no recording available at the time with this study. So it was ambulatory study with no video. In 73 patients out of the 101, so approximately 73%, data contributed to appropriate patient management. 31 patients were diagnosed as non-epileptic events. 15% were diagnosed with epilepsy, very similar to that previous study that we looked at. Both seizures and spikes were recorded. 100% of those patients had previously normal routine EEG. Again, a big observation there. 10 patients out of the 100 showed high frequency of seizures. So it was helpful in modifying treatment, very helpful. Sometimes people do tend to under-report seizures because some of them may be just things that they don't think are auras or epileptic events, yet they are. And some of them they're not even aware of. With complex partial seizures, they might not be aware of their seizure, or some of the nocturnal seizures, they might not be aware of them. 3 out of 3 patients referred for exploration of epilepsy surgery candidates did show generalized epilepsy or generalized spike waves. So those were just kind of dismissed in terms of surgical evaluation. So we did not send them to the EMU. We actually avoided an EMU admission by doing a short home test because they have generalized epilepsy and obviously not candidate for epilepsy seizures. I don't know if we're running out of time, but I can go a little faster unless you guys are enjoying this. 3 out of the 3 patients referred for surgery candidacy showed focal epilepsy and were referred to inpatient. So just the opposite of what happened with the generalized. With those generalized, we said, okay, you don't have to go to the EMU, you're not a candidate. On the other hand, 3 people that were referred to see if there would be candidate, we did a 3-day study and we found focal epileptiform discharges, send them to the EMU for further deeper evaluation. 1 patient with established diagnosis of epilepsy showed both epileptic and non-epileptic spells. Actually, the non-epileptic spells were more frequent, and that helped with managing the patient. So we didn't have to go on increase medications or add medications every time they told us they had a spell, because now we were able to distinguish what was epileptic, what was not. 6 patients had one single unprovoked event and had been started on medication. Now, with this study, all of the EEGs were negative. With the high negative predictive value, this was helpful to stop their medication and tell them this was a one-time seizure and not epilepsy. So the conclusion is that it contributed, the ambulatory EEG contributed to the diagnosis in 71% of the patients. One disadvantage was the missing of electrographic epileptic changes in certain types of seizures, which again, in the EMU, you can miss them, but without video, with video in the EMU, you might be able to actually diagnose seizures, some stereotypical events as epileptic seizures, even with no EEG correlation. Not having video on this, in this study, if you have a simple partial seizure, we didn't see it, and we didn't actually capture it on video, and we didn't see it on EEG, we could have missed it. Third study in 2019, large population, but this was a retrospective study, looked at the diagnostic outcome of ambulatory versus inpatient in pediatric and adult patients. The primary outcome is the percentage of video EEG recordings that capture at least one button activation, the push button, on video camera and demonstrated activity, epileptic activity on EEG. The primary outcome is that almost 62% of the patients reached primary outcome with the ambulatory and 54% with the inpatient video EEG monitoring. 72.5% reached primary outcome with the ambulatory in children versus 86% with the inpatient. So some better better in children. For the inpatient EEG, there was a better primary outcome results. So video EEG showed more electrographic seizures than the ambulatory EEG. Inpatient EEG showed more electrographic seizures than ambulatory EEG. And only 0.3% of all those studies that they reviewed were uninterpretable because of artifact. In conclusion, for them, the ambulatory video EEG with this large population looks back retrospectively was very useful in the non-urgent and non-surgical evaluation of paroxysmal event or seizure-like events. Inpatient is medically necessary when there is the need for acute medical intervention, and then when additional testing is required, such as ictal SPECT, functional MRIs, you can do all of that in one admission while they're in the EMU, or when AED reductions are needed to bring on seizures. It's more appropriate for evaluation at academic epilepsy centers. The ambulatory EEG, on the other hand, is more convenient and appropriate in community neurology healthcare settings. It's also convenient when basically you're in the EMU, but you have limited number of beds and your waiting time is 3 months, and you can't really wait to make a diagnosis and start treatment or stop treatment because you have to wait 3 months to get the patient in the EMU versus doing a quick study 2 weeks or 4 weeks down the road, getting the results in and deciding what to do, whether to stop medication, start medication, change medication, or even refer down the road to the epilepsy monitoring unit for further evaluation. When I say new direction, this is where we come at basically the COVID era. I mean, before COVID, we've done a lot, but during COVID and after, overall and in general, telemedicine has become very popular, especially, I mean, popular amongst doctors, don't get me wrong, we love it, but also very popular amongst patients. If we ask a patient whether they want to do telemedicine consult or inpatient consult, at least 50%, if not more, will tell us they would just, at least for now, let's just do a telemedicine consult. Let's do it over the phone. I don't have to be in. I'm not having significant symptoms. I'm just wanting to discuss some things. So again, stay-at-home orders here in the US, things are closed for elective surgery. You got to put a mask, not convenient. So obviously the choice here is quite clear in terms of what patients want. So it is becoming a major part in healthcare management because of the ease of access, the safety issues, and all the lockdowns. The increasing number of people working from home, as we said before, if you're home and you want to get an ambulatory EEG, you can do it. You don't have to take time off of work. The risk of hospitalization and contracting COVID, and then the avoidance of non-urgent or elective procedure by hospitals. So we have now more or longer waiting times. My personal experience, real quick, I've been running, like I said, an epilepsy monitoring unit and an epilepsy clinic for 3 years with a 3-bed EMU. The average EMU scheduling time ranged from 4 weeks to 12 weeks most of the time versus the ambulatory, which I did a lot as well. So was 2 to 4 weeks. And then when either test was appropriate, 80% of the patients in my practice actually wanted to do it at home when either test was appropriate, as I thought clinically. And there was definitely a high rate of patients leaving the EMU early than discontinuing their ambulatory EEG. So when you come in and you schedule a patient for 5 days in the EMU, higher chances the patient is going to leave earlier because of some emergency at home, or can't stay longer, or they're getting too anxious, versus just being at home. There's a less chance of discontinuing a study at home. Insurance approval, I discussed that earlier, is definitely higher currently for ambulatory video EEGs. Most of the insurances are telling us to do an ambulatory EEG before they approve an EMU. And even for routines. Now, if we say there's only the government insurance currently that requires routine EEGs to be done before an ambulatory EEG, not a video, not an inpatient, but an ambulatory. So most insurance companies will accept you to do an ambulatory video EEG without having to do routine EEG, most. So here we come to the solutions or the services that are available for you guys, everyone who's thinking about it or willing to do it. Neurovation Solution is a company that I've met recently. I have known some of the administrators and for a long time. They are partnering with Lifelines Neuro and Neurovative Diagnostics. It comprises a network of experienced epileptologists, electroencephalographers, EEG technologists, engineers, and administrators. And this network has been together for a long, long time, now kind of consolidating their effort to provide those services in the Middle East area and in Saudi Arabia or the United Arab Emirates. But this service together, these people have been doing this for a long, long time. I've been working for them, or with them, I'm sorry, for a long, long time. So they've been doing the inpatient and ambulatory EEGs for several years in the US. Like I said, I've been interpreting a lot of their EEGs. There's excellent EEG and video recording quality. There's the ability, currently, live monitoring. I mean, intermittent live monitoring is being done in the inpatient setting and in the outpatient setting, with daily monitoring being done in the outpatient setting almost routinely. There's rapid scheduling and turnaround time. There's the logistic and tech support 24/7. And then the database for doctors who want to read their studies. And the server is really, really very user-friendly. It takes literally a few minutes to get on there and kind of learn it. And I know some of the other ones are like, Natus or, Neoncodo, and some of those that I use a lot are quite complicated. And it takes a while to get used to them, but not here. It's really easy. I'm putting some samples here. This is really, I mean, literally, I didn't have to fish for samples to get good pictures. This is a sample from an EEG that I read recently. This is an awake patient. As you can see, the blinking artifact, there's minimal, just the frontalis here a little bit, but minimal otherwise all artifact that is obscuring. It's a beautiful quality here in terms of an awake EEG. This is a sleep EEG. As you can see, even subtle changes like this slowing here compared in the right frontotemporal region compared to the left, you can see it. So this is really a very good quality. I'm going to run a video here for you guys as an example, just so you can see. This is a video, as you can see, it can be zoomed in, zoomed out. You can actually move it around and right, left, up, down. So really, really a very, very good quality. This is at night, mind you. This is at night, so no light, it's dark, and you can see it. If this patient has a seizure, we'll definitely be able to see it and determine some of the little details of it. And this is just a quick picture of the actual software itself. This is render, where basically a doctor goes in. These are the studies that the doctor has performed or read before, studies for them to review, studies in progress. You go into a patient list where all the if in the, depending on how you set up your needs, where I go into my patients or the patients here, I can see a preliminary technologist report. I can edit that report and put my own interpretation, or you can actually write a report outside of Render and just drag it in and upload it to the patient's report or patient's chart, and it will be available for everybody to see. So really very, very user-friendly. So I'm going to stop here, and before we go to questions, I'm going to let Dr. Al-Jafari run a small video for you guys as well to kind of introduce you more to the Neurovation solutions and what they do and some of the technical components of it, just to have a better idea. And then we'll be open for questions for everyone. Dr. Al-Jafari, the mic is yours.
Thank you so much for this wonderful talk, and it's very informative. So I'll share the video now, and then we'll go to the Q&A section. Just give me a second. Can you just stop sharing your screen? So
oh, sure. I'm sorry. Let me stop sharing that. Here we go.
المعضلة الأساسية اللي كنا دائما عم نواجهها مع الأطباء أنه أساليب العلاج موجودة، ولكن الدقة بتشخيص المرض قد تكون أكثر أهمية من الذهاب إلى العلاج مباشرة. كان دائما من خلال الذهاب إلى المستشفى والمبيت بالمستشفى لمدة أيام. فالحل الأنسب هو أنك أنت تحرر التشخيص من قيود البقاء بالمستشفى.
While you're at home, you're able to continue with your daily lives and your daily activities. Being at home, they could recreate that activity for us to be able to capture that episode itself. Whereas if you're at the hospital, it makes it very difficult to be able to do that because you're not in your same elements. Definitely at home, it's going to be cheaper than being able to then going into the hospital. In the hospitals, you have to deal with all the extra expenses of the rooms. In the EMU, you'll have the physician, the equipment, and then the technology. With ambulatory, we still have the physician, we'll have the equipment, we'll have the technologist available, the monitoring department, and then we'll include the patient as well. With all these advancements, we've been able to capture and help diagnose better, quickly, and more efficient.
أولاً يقوم الطبيب بتحويل المريض للفحوصات المطلوبة بالوقت المطلوب، ثم بعد ذلك يقوم الشخص المختص بالاتصال بالمريض وتحديد المواعيد المناسبة له. بعد كذا يقوم الفني بزيارة المريض في منزله طبعاً وتركيب الأجهزة المطلوبة، ويقوم بتوقيع الأوراق المطلوبة اللي هي الموافقة على إجراءات الفحص. بعد ذلك يتم تركيب الأسلاك على رأس المريض، ثم بعد ذلك يتم مراجعة الفحص كل ساعتين من قبل الفنيين المختصين بذلك.
سيتم التسجيل لمدة تفوق عن 24 ساعة أو يزيد. قد يعود الفني بعد ذلك في حالة خلل في بعض الأسلاك لإصلاحها. ثم بعد انتهاء المدة المرادة سيعود الفني لإنهاء الفحص وإزالة الأسلاك عن رأس المريض، وبهذا تكون انتهى الفحص. ما يلي ذلك سيكون عن بعد بعد اطلاع الطبيب على ذلك وقراءته وإصدار التقرير عن الفحص المسجل.
We have a very in-depth policies and procedures that encompass every aspect of our services. These policies and procedures are being monitored, reviewed by our medical directors who are certified epileptologists. These policies and procedures are in accordance to ACNS guidelines.
هيدا هو السبب اللي خلينا نحن نعمل شراكة مع شركة لايفلاينز نيورو. لايفلاينز نيورو هي الرائدة بهيدا المجال. خلال ال20 سنة اللي مضوا شراكتنا مع نيوروفيتيف دايجنوستيك كانت كتير أساسية. عندهم أكثر من 50 سنة من الخبرة من خلال الفريق تبعهم، هن معتمدين، عندهم كل الشهادات المعتمدة. بهالطريقة نحن قدرنا نمزج بين التكنولوجيا الرائدة من جهة وبين الخبرة وبين الحاجة ببلادنا.
Okay, thank you so much, Professor Aglakian. It was a wonderful talk.
It's my pleasure.
So we received some questions, if you allow me to proceed with the questions.
Of course.
The first question is about the safety of weaning off or reducing the dosage of anti-seizure medication while doing ambulatory EEG monitoring. If you follow the same protocol as in EMU, and if you provide patients with a rescue medication or like a short-acting benzo at home while having a seizure?
That's a very good question. Now, overall, the general answer to that is most of the time we try to avoid reducing or making changes to the medication during an ambulatory video EEG. Having said that, there are instances where we would do it, but in a very safely manner. One reason I sometimes reduce or stop medications during the ambulatory is if I have a high suspicion of a patient being diagnosed with epilepsy and seizures and started on medication, yet in my mind, I believe they are non-epileptic. So for that, I do ask patients, I write them a schedule to taper it off, pretty much the same way we do in an inpatient EMU setting. 1 or 2 days before the study is performed or is started, and then 1 or 2 days tapering off as the study is going on. For patients like that, I feel relatively safe to do it because clinically, most of them have been started usually on medication by their family doctors, thinking they have epilepsy when they have been describing some seizure-like episodes. But when they come to us as neurologists and epileptologists, we ask for those special details, little things in the history that often gear us towards this is epileptic or this is not epileptic. If we have a high suspicion, yet we want to diagnose it for sure, we can do that and gradually reduce it. In patients where we're trying to quantify seizures and determine what their seizures look like and the focus and whatnot, we have to understand that we don't necessarily have to reduce their medications all the time. If patients have seizures despite being on medication, you don't have to reduce their medications because you can monitor, and you can monitor as long as you want in the home setting, and you don't have to reduce their medication. On the contrary, especially now with the intermittent and the daily monitoring, if a patient has a seizure at home and we diagnose it as epileptic by looking at the ambulatory EEG that day, we can actually increase their medication or adjust them while they're at home. But we won't necessarily have to reduce their medication at the onset. So there is a number of cases where we can reduce it safely. A lot of instances or patients, we do not have to reduce it, even if they're on medication, because they have a high burden of seizures. So they have a lot of seizures. So we're going to catch them regardless. Or we need to increase their medication. And we can do that safely, obviously, at home. The rest of the patients either are going to have to be in the EMU, or if I were to reduce them, it has to be very slowly. And I do, yes, at times, give them the rescue medication, a small dose of Ativan to use for a seizure lasting more than a couple of minutes, and immediately contacting the doctor or the ordering doctor, myself, or whoever that doctor is, to inform them of the actual seizure so medications can be restarted actually right after we can look at the EEG of that day.
Okay, thank you so much. Another question is about pass without capturing any events or interictal discharges. Do you extend the procedure?
Yes, actually, it wasn't my study, but I have read a study that actually went on for 30 days. 30 days. A patient was able to tolerate it, and the doctor said, let's do the study until we capture an event. And it was a 30-day study. And so there is really no limit. That's the good thing. There is no limit. Usually it's 7 days. Some people order 14 days. It really depends, because a lot of patients, when you ask a patient about their seizures, they average once a week. Let's say they average a day. Their average once a week, once every 2 weeks, a 7-day test study. If they say once every 2 weeks, Yes, that's what I talked about, the flexibility of the study. You can start slow. You can start with the 3-day study and extend as long as you'd like. Or you could do the opposite. You could start very high. You can order the 10-day and stop as soon as you capture an episode. That's where the flexibility is with the ambulatory studies. Yes.
Question about the technical problems. So about the live EEG tracing, or the technician access to the tracing. So can it be remote? So if there is any technical problem, electrode artifact, they can call the patient to come to hospital and fix it, or what do you do usually? In
the way we do it here, the way we do it in the US, and but Neurovative Diagnostics, who's basically now, partnering with Neurovation. The remote access is very easy for technicians and for doctors, both. We actually, as physicians, can access the same thing the technologists can access at any time during the study. And you could leave it running live 24/7, okay? Now, in terms of being able to fix something, if an artifact is obvious in a way where the patient can fix it, the technologist will call the patient and say, that electrode number, whatever, is probably a little loose. Go ahead and push on it and get the sticker to stick better, and we'll look at it again. If that does not fix the problem, or if it's a problem that requires the technician to fix it, the actual technician in here will go to the patient's home. They will go to the patient's home and adjust it. So this is all set up at the patient's home. An artifact is fixed at the patient's home. Nobody's required to come to any hospital or clinic.
Okay, great. Two more questions. One is about any differences between children and adults in terms of application and results.
So we talked about, one of the studies did compare the adults and children. The last one we discussed, there was a little more of the spells kind of like caught during the inpatient monitoring of children than there were. But again, the study was not very statistically, the numbers were not statistically significant. So it's more about the practicality. There's not a head-to-head. Again, that study, I could go back and take a look at it. Show it to you, but just to kind of tell you a little bit about what they saw in children versus adults. In adults, they reached their primary outcome, which was basically seeing or push button and being able to capture an event and see epileptiform activity. For adults, it was 61% versus 54% for inpatient. For children, it was 72% kind of seeing those capturing at least one event and seeing epileptic activity, compared to 86% for inpatient. So there is a little bit of difference there, a little bit better. However, on the practical standpoint, our pediatric neurologists have been much more satisfied with the studies that they're getting at home and the length that they can do at home, especially in younger children, than they're satisfied with the ones they're doing in the hospital.
Okay, thank you so much. Last question is about selecting the patient for epileptic, non-epileptic event, or it's like a prolonged procedure to capture interictal discharges, or also do you use it for pre-surgical evaluation?
I could tell you it's all of the above. It's all of the above. If you look at the number, the two things you cannot safely or routinely do in an ambulatory setting is, like we talked about, medication changes and reduction. And number two, in-depth surgical or pre-surgical evaluation with other testing, right? So basically, here's how I see it. I see no restriction for anybody to get an ambulatory EEG except those two exceptions. Somebody who's known epileptic, or somebody, who is on medication and we know we need to reduce the medication to be able to catch an episode. The other one is we're doing surgical or pre-surgical evaluation to look at the actual focus and maybe go to phase 2 invasive monitoring and other tests like ictal spect, functional MRIs, and all that stuff. But everybody else, if you look at it, anybody who you can refer for a routine EEG, you can refer to an ambulatory EEG. Anyone. If you refer to a routine EEG, that means you can refer to an ambulatory, because it's the same patient population. It's the same questions you're trying to answer. Epileptic versus non-epileptic. Number of potentially number of, or quantify seizures, number of seizures in a week, quantity of inter-ictal epileptic discharges. Are these happening once every few hours, or do we see one spike every few minutes during sleep? All of these questions you can answer with an ambulatory EEG. Therefore, the use is so wide ranged that, in my opinion, there's very little limitation as to when you should not send somebody to the ambulatory and just send it to the EMU. And again, one thing I want to make sure you understand, let's say you want, even as an intermittent test, being relatively lower cost than the EMU. If you have an EMU with a waiting list that is 2 months, which is relatively that average here, in those 2 months, you're doing nothing for the patient, really. You're just basically waiting for a test. But in the meantime, you could do an ambulatory EEG and figure out whether they have epilepsy, number one, figure out the burden of seizures, number two. And a lot of times you can say, figure out that they're having both epileptic or non-epileptic spells and say, listen, you don't have to go in the EMU anymore. But that answer you can have within 4 to 6 weeks compared to waiting 2 to 3 months just to get into the EMU. So a lot of times you get that EMU ambulatory EEG and maybe you don't have to send them to the EMU anymore because of that waiting time.
Thank you so much. I think we came to the end of the webinar. On behalf of Saudi Epilepsy Society, we would like to thank Professor Roger Oglekian for this wonderful talk, and thank you for being with us tonight. Also, thank you to our audience. I would like also to thank Worldwide Academy Event for organizing this activity and your innovation company for sponsoring this activity. So have a wonderful night and goodbye. Thank you so much.
Thank you very much. It's been a pleasure. Thank you.
Bye.